This is Chase Unruh and Dr. Mayeda's HPR 1040 medical terminology class during the summer semester of 2025. Thank you for taking the time to watch my presentation on peripheral artery disease, which is also known as PAD, peripheral arterial disease, and peripheral arterial occlusive disease. This is of particular interest to me because I was diagnosed with PAD in January of this year. During this presentation, we will explore the definition of PAD, how it is diagnosed, its causes and contributing factors, and my personal experience with this disease. I hope that you learned something of interest to you or to your loved ones. As we have learned this semester, pausing to analyze the words used to describe a disease is extremely helpful. For that reason, consider that the word peripheral refers to someone's extremities or their arms and legs. The word artery is used to describe blood vessels that carry blood away from the heart, and the word disease refers to an abnormal condition that affects the structure or function of part or all of the body and is usually associated with specific signs and symptoms. In particular, the word artery is helpful when differentiating arterial versus venous diseases, such as peripheral artery disease compared to deep vein thrombosis, which are both vascular conditions affecting the limbs, but differ in the affected blood vessels as well as their underlying causes and symptoms. If you are like me and have never pondered the definition of the word disease before this class, please consider reading Jackie Leach Scully's brief viewpoint article, What is a Disease? You can find the reference to this article at the end of this presentation. I would encourage you to read this because, as Dr. Scully mentions, how we define a disease has consequences for sufferers, for their ability to have treatment reimbursed by health service providers. This article may also be of interest from historical and anthropological perspectives. Returning to the definition of peripheral artery disease, let us consider two definitions. First, our textbook defines it as an example of a peripheral vascular disease that is caused by atherosclerosis. As you may recall, atherosclerosis is the hardening or narrowing of arteries by a buildup of cholesterol plaque on the interior walls of the arteries. Combining our book's definition of PAD with the definition from the U.S. Centers for Disease Control and Prevention's website brings even more clarity. Peripheral arterial disease, PAD, in the legs or lower extremities is the narrowing or blockage of the vessels that carry blood from the heart to the legs. It is primarily caused by the buildup of fatty plaque in the arteries. So, peripheral artery disease is a disease most commonly in the arteries of the lower extremities caused by atherosclerosis. The reason that we should care about this disease is that the affected arteries supply blood to a person's extremities. Without an adequate supply of blood, the person experiences hypoxia, which is a condition of having deficient oxygen levels in the body tissues and organs. PAD has many contributing factors, but the primary cause is atherosclerosis, which is detected using a non-invasive ankle brachial index, or ABI. ABI is calculated by dividing the blood pressure in the patient's ankle by the blood pressure in the patient's arm. If that ratio is less than 0.9, it can be indicative of peripheral artery disease. We will return to an explanation of ABI momentarily, but please take a moment and just read the Johns Hopkins University's explanation of PAD in the slide. Although in my case, my genetics are responsible for producing a low-density lipoprotein, commonly referred to as LDL, or the bad cholesterol, the particular LDL my body overproduces is lipoprotein A, also called LPA or Lp(a). Although LPA is related to PAD in my case, I'm going to ignore this particular aspect of the disease. Instead, I'm simply going to cover controllable and uncontrollable contributing factors. These include smoking, diabetes, hypertension, hyperlipidemia, also known as hypercholesterolemia, or simply high cholesterol, aging, a sedentary lifestyle, obesity, a family history of vascular disease, and ethnicity. Now that we have discussed what PAD is, its cause, and some contributing factors, let us take a moment to return to a very powerful tool used in the process of diagnosing someone with PAD, namely the ankle brachial index, which is a simple test that compares the blood pressure in the upper and lower limbs. Healthcare providers calculate ABI by dividing the blood pressure in an artery of the ankle by the blood pressure in an artery of the arm. The result is the ABI. If the ratio is less than 0.9, it may mean that a person has peripheral artery disease in the blood vessels in his or her legs. In this slide, you can see how a medical professional would acquire an ABI. You can observe the placement of the sphygmomanometers or blood pressure cuffs around the person's brachia and ankles. What the picture does not show, but that I experienced, is the use of a Doppler ultrasound. Here's a picture of someone using a Doppler ultrasound. These can be small handheld battery-powered devices, or they can be larger, more stationary machines. In both instances, they are capable of producing waveforms somewhat similar to those of your heartbeat. In the context of an ABI, it is typically used to detect the pulse of the dorsalis pedis artery on top of your foot, but can also be used on other arteries in your feet when, as in my case, it cannot detect blood flow at all. Here are some Doppler waveforms from my last ABI. On the left-hand side of the screen, you can see the waveforms for the right posterior tibial artery, the right dorsalis pedis artery, and the right hallux or big toe. On the right side of the screen, you can see the difference in blood flow by observing the much smaller crests of the waveforms for the left tibial artery, the left dorsalis pedis artery, and the left hallux. This is an example of the diminished blood flow to a person's extremities that results from peripheral artery disease. When there is sufficient evidence of peripheral artery disease, a physician may order a CT angiogram, or even more simply, just a CTA, to pinpoint the location of any blockages. Sometimes a CTA is referred to as a CT runoff. You may recall that a CT means computed tomography. You may also be wondering whether a CT and CAT scan are the same. They are. But whereas CT means computed tomography, CAT means computerized axial tomography. The CT angiogram on the screen shows my left leg. The contrast allows the arteries to be visible. You can most easily observe my femoral artery superior to the knee. Although my femoral artery appears to stop, that is just a result of this one particular image in the overall set of images making up the angiogram. However, what is consistent throughout the angiogram is the blockage below my popliteal artery. Notice the abrupt disappearance of my fibular and posttibial arteries branching off of the popliteal artery. To me, that looks like a pretty small block, but has had nearly catastrophic results, including the threat of amputation of a portion of my left foot. Please take a moment to read this case study. This is me, of course, but you can read a little bit about how I presented whenever I first sought care for what I thought was just muscle pain. I presented to urgent care in February of 2024 as having muscle pain that prevented me from walking, but my pain improved gradually over the next year to the point that I could ski, hike, and play hockey. Then, at the end of December, my symptoms returned one day after being in the mountains, only this time it was much, much worse. I tactfully bugged my physician's clinic until they could figure out what was going on. I could barely walk. Again. So they ordered an ABI after feeling a significant temperature difference between my left and right feet. This temperature difference was due to a lack of blood reaching my left foot. After the initial ABI, my physician and her PA also found a diagnosis of hypercholesterolemia due to the high levels of LPA, which caused atherosclerosis, which caused peripheral artery disease. Due to this threefold diagnosis, I now receive lipid apheresis every 14 days. Although the damage to my legs is irreversible, my condition is being managed. I apologize for inserting myself so much into this presentation. However, I did so because this has been one of the most significant challenges of my life. PAD completely altered my ability to pursue recreational activities that I have enjoyed for my entire life, and although I am in a much better place now, the mental struggle of adjusting to life without those activities has been one of my greatest challenges in life so far. If you take away anything from this presentation, I hope that it will be this. When dealing with patients, I believe it is important to remember that they are complex human beings and not just statistics, data points, or a health condition to be cured or managed. Thank you.